Revascularization is the topic of chapter 15, and there are just a couple different techniques of doing it, and the hope is that if you can revascularize before an individual has an event, an acute myocardial event such as sudden cardiac death or a heart attack. It is either a minimally or intensive or very invasive surgical procedure, and its purpose is to re-establish blood flow to the area beyond the narrowing or the clot. The testing to determine if someone needs revascularization is going to be our graded exercise test, where we're looking for changes in the EKG, or if somebody is having signs and symptoms, an invasive, or it's basically invasive, coronary angioplasty can be done to see where the narrowing is occurring. Angioplasty is designed to open a blocked or narrowed blood vessel. Bypass surgery is when you bypass a blocked vessel. It really reduces the number of deaths and heart attacks. However, there are risks. It is a very invasive procedure, and there are many risks associated with it. One being stroke. The PTCA, or angioplasty, again, is when you're opening a narrowed blood vessel, and many times a balloon would be used, or percutaneous coronary intervention. Most often a stent is used, and that is often preferred because it is not as invasive as a bypass. Coronary artery disease is going to be the mechanism behind the development of the atherosclerotic plaque. And something to pay attention to is that we often do not have symptoms until a significant amount of narrowing has occurred, and it appears that the threshold is about 75% blockage. You have two ways of looking at it in this picture. You have the narrowing from cross-dimensional, but also looking at it straight on. And when you get to 75% occluded of the cross-sectional decrease, you start to see changes on the EKG or more symptoms. The bypass surgery is done utilizing a venous graft, and if you recall, in an earlier class time I mentioned that the atherosclerosis tends to occur to specific blood vessels. Those blood vessels were around the coronary artery, the femoral artery, remember a couple other, the specific places. But veins tend not to have that occurring, and so the revascularization uses a venous graft often from an arm or a leg, and this was historically how it was started. So you start by taking a vein from another part, from the arm or the leg, usually the leg, and kind of sew it on on the ascending aorta, and sew it beyond the place where the blockage occurs. However, there's been tremendous advancing in terms of what vessel is used and how the procedure is done, and there's some interesting reading in the book. I'll tell you that when my father had his quadruple bypass, they harvested a vein, and individuals that do that vein harvesting in their leg, they often have that as even more painful as the surgery itself, which is quite interesting. The development of using the left internal mammary artery is shown in this picture, and you'll see that there's a left and there's a right internal mammary artery. It's coming right off one of the first branches off the aortic arch, and so it's got a nice direct blood flow, and it is attached to this space below the blockage to reestablish flow beyond the block or the narrowing. And I should say it's grafted rather than attached. That's a better term, grafted. The beating heart surgery is really quite interesting. The bypass suggests that you are attached to a machine that the heart is stopped, and the machine oxygenates the blood and brings it back to the body and acts as if it's the heart. That does take more time. It's also much more more timely, and it's been developed to use a beating heart, and with that they don't stop the heart. They basically put it in a clamp and hold that heart still or relatively still as they graft those vessels on. So that's the beating heart surgery. Minimally invasive surgery uses or includes using robotic technology to have a much smaller incision, better healing, but of course you can't be an individual that needs 5 bypasses for that. Here is I would say, relatively simplistic way of looking at this. Here they have a vein graft that's coming off the aorta and also utilizing the left internal mammary gland beyond the plaque. And here's this, you have an individual that's got 4 bypasses or a quad bypass. People live much longer and get out of the hospital faster than what they did when this procedure was first introduced. But it's not used as frequently. It's now, bypass surgery is used when somebody has a less invasive procedure that just fails multiple times, or restenosis. An individual who is unable or is not a candidate for other for angioplasty, where I'll show you that picture in a little bit. And if somebody has too many vessels that need to be or too many blockages, then it is something that's typically reserved for. So coronary artery bypass surgery, or CABS, was also known as cabbage, and it was coronary artery bypass graft. So you'll see cabbage or CABS. PTCA, or percutaneous transluminal coronary artery procedure is if a stent is added, it's called percutaneous intervention. And this is really a first step, unless it's an emergency, utilizing either a balloon or a rotor-rooter, which is atherectomy, removal of that atheroma, or using a laser. This picture shows a wire mesh that's been introduced, and what that does is it holds that vessel patent so it stays open. Here is removal and atherectomy, where there is different ways where it can rotate. It can be like an orbital sander, or it can just be in one spot. So those are just to give you an idea about the different ways of removing that material. There are complications, although restenosis has really dramatically decreased since the addition of the drug-eluting stents. If you add the drug non-clotting component to the stents, it makes the complication or the rebound rapid restenosis much less frequent. You have a longer time frame where that stent will be functional. You can have rebound vasoconstriction, particularly if you take some of that material out or you put a balloon in. It can be almost irritated and cause vasoconstriction post the procedure. An embolism, an MI, or the coronary artery can split or dissect or bleeding. So there are risks with this procedure as well. We do know that adding the addition of the drug-eluting component or drug-eluting substance on the mesh, on the stent, has really helped, and that in addition, if someone takes an antiplatelet medication for the first year, they tend to have less failure with their stent. And as these stents develop, we'll see that we'll have even greater improvements. This, I think, is really interesting. This is a hybrid revascularization, and this is where you treat the left anterior descending coronary artery, which is known as the widowmaker, the one that goes right down the front, feeds the left ventricle, which is the strong pump to the entire body. If you use the bypass, using that internal mammary artery for that, and then use stents for the other vessels that are non-left anterior descending, we see that the mortality and the outcomes are much improved. So on the right-hand side, you see conventional, all vessels have the bypass, versus the hybrid, and you'll see that after 6 years, 14% versus 19%, and subsequent revascularization, 12 versus 23%, is really quite remarkable. With a CABG, as I mentioned, you have greater stroke risk, but it is better if you have many vessels that are blocked, and it is helpful for, especially with multi-vessels, for improved morbidity and mortality. With the PTCA, individuals are less likely to attend cardiac rehab, and then we get a new problem with that. The stent therapy, we know, I guess this is pretty much what I've already mentioned, so I'm just going to move on here, but this is a one-day stay or same-day stay versus someone staying in for a week. And the recovery is much easier with a stent versus the very invasive cabs. The outcome of having any revascularization procedure is going to be influenced by a number of factors, and they're going to be on the next table, table 15.1, which I'll let you take a look at. But it depends on age. The older you are, the success rate as someone gets elderly in their 70s and 80s, the success is more, they have more disease. The more comorbidities a person has is going to influence the outcome success rate, and also the location of where that revascularization procedure occurred. And I'm going to encourage you to look at table 15.1 to get an idea about what the predictors are.